Good morning. Now I am going to present a lecture on destruction osteogenesis. Destruction osteogenesis of the craniofacial skeleton has become increasingly popular as an alternative to many conventional orthognathic surgical procedures. For the patient with mild to severe abnormalities of the craniofacial skeleton, destruction techniques have increased the number of treatment alternatives. The destruction of osteogenesis is a biological process of new bone formation between the vascularized margins of bone segments when they are gradually separated by an incremental traction. In 1905, Cody Villa performed the first bone destruction on the femur. In 1927, Both applied the same concept to the lengthening of tibia. Rosenthal applied it to the maxillofacial region. However, because of the high complication rate that included the skin infection, tissue necrosis, and the unpredictable reossification of the expanded bone, the destruction of osteogenesis did not initially gain clinical acceptance. In 1954, Ilizov began his work on lower extremity. He was a Russian orthopedic surgeon who began using the technique that combined compression, tension, and then repeat the bone compression to the heel fractured long bones with segmental defects. Based on his work in these patients, he pioneered the radical concept that bone generation could be initiated by piezoelectric effect of the tension rather than the compression. 10 to 15 years later, he expanded his technique to include the treatment of short and lower extremities. The destruction osteogenesis remained a long bone treatment till 1972. Zinder et al. Used a Swanson external fixator to lengthen the canine mandible. He surgically shortened one side of the mandible by removing a 1.5 cm segment and then allowed the bone to heal. This created a large crossbite that was surgically corrected 10 weeks later by attaching an external fixator, performing an osteotomy, and then slowly. In 1975, Bell and Edgar described a technique of rapid parietal expansion. Indications of destruction of osteogenesis: unilateral and bilateral craniofacial microsomia, developmental micrognathia, Treacher's-Collins syndrome, Perry-Robin syndrome, and Nager syndrome, midfacial hypoplasia. The transport destruction has been shown to be useful technique for regeneration, that is, newly forming bone of the mandibular condyle. To correct the mild skeletal class 2, to expand the mandibular symphysis, to skeletal correct lower anterior crowding, condylar hypoplasia, TMJ ankylosis, post-traumatic growth disturbances, aid for ridge augmentation, recently for rapid canine retraction. Contraindication: poor nutrition, lack of soft tissue, inadequate bone stock as in neonates, geriatric patients due to the decreased number of mesenchymal stem cells and repair, irradiated bone, osteoporotic bone, any systemic disease which affect bone metabolism or contraindicated generally. Advantages: need for orthognathic surgery is minimized, and so are the complications associated with orthognathic surgery, shorter hospital stay, less likelihood of nerve injury, reduced need for intermaxillary fixation, reduced postoperative pain and swelling, less likelihood of idiopathic condylar resorption, greater range of maxillary advancement is possible. Disadvantages: poor 3D control on the segments with current distractor device. The 3D distractor are being constantly modified for desired results. The daily manipulation of corticotomy, one or several times a day, could give rise to pain. The difficult access for orthodontists during distraction in consultation stages as a distractor could obscure the buccal segments. The difficult plate control. The damage to the TMJ due to incorrect vector orientation. The technique sensitive surgery. Equipment sensitive surgery. High cost of the distraction appliance. The need for second surgery to remove the distraction device. The biology of the distraction. The distraction as a technique is divided into two categories depending on the anatomical site. The predominant method of distraction in the maxillofacial application is calotosis or distraction of healing callus between the bone fragment after a corticotomy or osteotomy. Ilizov's law of tension stress. A steady traction is applied to the bone fragments after corticotomy or osteotomy. The bone can be lengthened by by the formation of new bone at the surgical site, and it is a healing callus that actually give rise to the regenerate bone. The phase of destruction osteogenesis. The clinical destruction osteogenesis consists of 5 sequential periods: osteotomy, latency. During the duration from the bone division to the onset of traction, distraction, the time when the gradual traction is applied and the destruction regenerate is formed. Consolidation, the period that allows the maturation and corticalization of regenerate after the traction forces are discontinued. Remodeling, which expands from the initial application of full functional loading to complete the completion of regenerate bone remodeling. Osteotomy phase, surgical sectioning of the bone. Osteotomy for destruction surgery should aim for maximum preservation of periosteum and endosteum to maintain the intact blood supply and the good venous flow and the viable source of cell required in order to initiate the perfect the destruction osteogenesis process. The traditionally fracture healing has been described as consisting of 6 stages or phases: impact, induction, inflammation, soft callus, hard callus, and remodeling. Latency phase. It is characterized by the initial inflammation followed by the formation of soft callus, hard callus, and calcification leading to the bone union. If destruction is begun too early, the result is decreased bone formation, often with cartilaginous elements present, and decreased mechanical strength of the newly created bone. If the destruction is begun too long, then the destruction device may be unable to further separate the bone fragments. The soft tissue callus phase begins 3 to 7 days after the injury and the last 2 to 3 weeks. This time frame set the boundaries of latency period. The destruction of the maxillofacial skeleton has been reported with immediate activation and with latency phases up to 12 days. With the destruction phase. After the latency period, the tension is placed on the bony segment by activating the planes. The two important variables in the activation: rate and rhythm. The rate, the amount of destruction per day; rhythm, how frequently the device is activated. The rate is 1.0 mm per day. The small, the risk of premature consolidation. The great, the undue stress on the soft callus, resulting in the thinning of all the dimension in the mid portion of the regenerate, and an hourglass at the destruction site. The continuous application of destruction force is ideal. Clinically, the application of destruction is the best performed by activating the device twice a day, that is 0.5 mm twice a day. If the patient experiences discomfort, the rhythm should be altered to allow for the smaller incremental application, 0.25 mm for 4 times a day. This is the radiographic imaging drawing demonstrating a 5-zonal structure of destruction regenerate. Consolidation phase. The consolidation period is that the time between the cessation of traction forces and the removal of destruction device. This period represents the time required for completing the realization of the destruction regenerate. After destruction ceases, the fibrous interzone gradually ossifies and one distinct zone of fiber bone completely bridges the gap. The total amount of bone formation seen in different types of regenerate varies, but the final percentage of trabecular bone increases from the end of destruction through 8 weeks of consolidation. Mineralization began at the host bone margins at the end of destruction and progressively increased up to the 4th week of consolidation, at which the time it remained stable for following 2 weeks. This decreased slightly from 6 weeks to 8 weeks of consolidation as the remodeling became the predominant activity of regenerate. Remodeling. The remodeling period is the period from the application of fully functional loading to the complete remodeling of newly formed bone. It takes a year or more before the structure of newly formed tissue is comparable to that of the pre-existing bone. Generally, the regenerated segments of bone show the relatively low mineral content and radial density. This is a schematic diagram representing the structures of destruction regenerated during the remodeling. Gradual colonization of remodeling zone with the formation of medullary canal and the residual host bone segment and cortical bone. Classification of destruction device. It can be classified broadly as an extraoral and intraoral device. Extraoral devices are further classified into unidirectional devices, bidirectional devices, multidirectional devices. Intraoral devices are classified as tooth-borne devices, tissue-borne devices, hybrid devices. external unidirectional distraction devices. In 1982, McCarthy et al. Introduced an external unidirectional distractor to successfully lengthen the mandible unilaterally and bilaterally. The amount of distraction varied from 18 mm to 24 mm. The distractor consisted of single calibrated rod with 2 clamps. Each clamp holds 2 mm half pins that are placed on the either side of the osteotomy. Approximately 20 mm to 24 mm of bone stock posteriorly to the last tooth bud is necessary to place this device. By turning the bolt on at the end of the rod, the distance between the clamps can be changed to prevent the expansion or the compression at the level of the bone. Molina distractors. Ortiz and Molina modified the Lizarow technique by performing an incomplete corticotomy. They left the internal cortical plate and the cancellous layer intact and used a semi-rigid external distractor. This has the capacity to further exploit the secondary soft tissue expansion associated with osteodistraction. Manual distractors or unidirectional changes in 3 dimensions have been documented. Disadvantages: scarring as a result of pin dragging through the skin during expansion, the difficulty predicting the direction in which the distraction would proceed, inability to change the direction once the distraction process has begun. External bidirectional distraction. The bidirectional distraction appliances provide an additional degree of freedom over the unidirectional device. Klein and Howard developed an external bidirectional device capable of achieving controlled changes in angulation. The device consists of 2 geared arms 5 cm in length connected to the middle screw that enables the arms to be moved up and down to change the angulation. The Molina offers an external bidirectional distractor based on the same principle as his unidirectional device. The multiplanar distraction. The ability to make the transverse changes was final step in achieving 3-dimensional control. The McCarthy et al. Reported their experience using an external multiplanar device to correct the asymmetry in the child with unilateral craniofacial microsomia. The multiplanar device consists of central housing with the 2 work gears in different planes. The 2 arms extend from the housing with the pin clamps at the either end. Each quarter turn of the wheel results in 0.25 mm of expansion, total 40 mm of linear expansion. The 2 activation screws enables the changes in the transverse and vertical angulation. The internal distractors. In 1985, McCarthy et al. Introduced an intraoral distraction appliance tested on the canine model. After osteotomy, the device was placed on the buccal surface of the mandible and the lengthening rod was extended into the buccal vestibule. The drawback of the appliance was that it could only accommodate 20 mm of expansion. Doctors Vasquez and Reiner developed 2 internal distractors for the lengthening of the mandibular body and the ramus. The Synthesis Maxillofacial manufactures a partially internal distractor. A tooth-borne intraoral distractor. In 1997, Razdolsky et al. Introduced a completely tooth-borne intraoral distractor capable of making linear changes. Current technique starts by fitting the preformed stainless steel crowns to the one tooth on either side of the anticipated osteotomy site. The vector of the distraction osteogenesis, biological and mechanical. The biological and mechanical forces that the shape regenerate are the key elements in determining the appliance position. The desired mandibular change in shape function can be achieved by selecting the controlling the force vectors that operate during the active distraction. The biological forces influencing the morphology of bone regenerate arise from the surrounding neuromuscular envelope. The mechanical forces under the clinician control originate from the activation of distraction device, their specific orientation to the skeletal anatomy, and the application of the intermaxillary elastics during the active phase of the distraction and intercuspation of dentation. It is important to note that the position of the device is best described in relation to the long axis of the mandibular body. The vector of distraction. The straight lines indicate the long axis of the device, vertical, horizontal, and the oblique. The line represents the long axis of the device in relation to the long axis of the mandibular body. In this planing method, the does not orient the device in relation to the posterior border of the ramus or the inferior border of the mandible because of the variability of morphology of these borders. Vertical device placement. Vertical device placement results in an increase in the vertical dimension of the mandibular ramus during the activation, and change occurs in a plane's orientation that appears to be caused by the non-linear modeling effect of neuromusculature on the regenerate as it is formed. The mandible auto-rotates in the counterclockwise direction, and the lower incisors can take a more advanced position, and the posterior open bite may occur on the side that has undergone vertical distraction of ramus. The device placed vertically in the mandibular ramus before activation. The activation of the device results in an increase in the vertical height of the ramus. Note the separation between the maxillary and mandibular dentition before the closure of the mandible. The mandible auto-rotates in the counterclockwise direction. The lower incisors may take a more advanced position, and the position and the posterior open bite may present itself on the side that has been lengthened vertically. Note that the bilateral vertical lengthening of the ramus is associated with the counterclockwise uprighting of the symphysis. This, along with the sagittal advancement of the mandibular body, contributes to the perception of the increased prominence of the lower third of the face. Horizontal device placement. The most efficient approach for achieving the sagittal projection of the mandibular body and symphysis is the placement of the distraction device in a horizontal position in relation to the mandibular body. The horizontal device placement results in the increase in anterior-posterior dimension of the mandibular body with the increased sagittal projection of the symphysis. There is a tendency in the horizontal distraction for the body to rotate in the clockwise direction, sometimes resulting in open bite. The pull of the supraoid musculature may have the role in the occurrence. There has been a reported improvement in the patency of the oropharyngeal airway and tongue position subsequent to the mandibular sagittal advancement. The oblique device placement. The oblique device placement results in an increase in the both vertical and the horizontal dimension of the ramus of the body. The effect of the oblique device placement in combination of the vertical and horizontal changes previously described, urged, and both ramen and the body size deficiency may be addressed by the oblique device placement. Surgical consideration. The surgical plan must include the selection of anatomical site, design of osteotomy, and the location of distraction holding device and orthodontics before, during and after distraction. The position along the plane vector of distraction. Prophylactic antibiotics performed under the naso-endotracheal general anesthesia. During the osteotomy procedure, due care should be taken not to avoid underlying teeth, roots of the teeth, and neurovascular bundle. In sagittal mandibular distraction, if the osteotomy cuts are placed distal to the last molar, the posterior or lateral open bite would be observed during the distraction. If the mesial to the last molar, an anterior open bite is expected. Bilateral sagittal split osteotomy can also be considered as an osteotomy design for a sagittal mandibular distraction. In case requiring a mid-face advancement, such as with operated with leaf-out osteotomy of cleft lip and palate, and the transverse maxillary deficiency, low-level leaf-out 1 osteotomy with the mid-palatal split is performed. The device activated initially 2 to 3 mm. The orthodontic consideration, treatment planning. The following points are considered while planning in case for distraction osteogenesis. Records, treatment planning sessions, joint sessions should be organized between the orthodontist and the team of surgeons. When planning a mandibular advancement, natural and the type of advancement must be considered, and the unilateral versus bilateral vector of the distraction and the site of distraction. Maxillary advancement in hypoplasia sagittal combined with the transverse. Maxillary advancement in cleft lip patients. Velopharyngeal and speech consideration. Orthodontic treatment protocol. The role of orthodontics in the treatment using a distraction osteogenesis falls into 3 temporal phases: pre-distraction treatment planning and orthodontic preparation, orthodontic or orthopedic during distraction consultation, post-consultation orthodontic and orthopedic management. The pre-distraction orthodontics, maxillary and mandibular dental arches are prepared for distraction osteogenesis by leveling and alignment decompensation, correction of the curve of P. The teeth should be moved to ideal position relative to the basal bone so that the ideal maxillomandibular relationship is not compromised by existing dental compensation. The coordination of both maxillary and mandibular arches followed by the placement of passive rectangular arch wedge with hooks for engaging the introarch elastic during and after the distraction. The osteotomy design, the distracted device orientation, masticatory muscle influences, occlusal interferences, orthodontic forces during distraction, and consolidation of face govern and affect the choice of the vector of distraction. In case of distraction and osteogenesis in children, the younger adolescents, the future growth prediction or over correction is recommended. In case of mandibular corpus distraction or ramus distraction, the 3 planes occlusal plane, mandibular plane and the ramus plane can be used as a guiding plane to orient the distractor device. Another component of pre-distraction orthodontic treatment is the fabrication and the use of distraction stabilization of planes. The appliances are placed before distraction and provide multiple opportunities for the use of intra-arch elastics to control the mandibular position during distraction, consolidation, post-consolidation phase. Orthodontics during the distraction and consolidation. Orthodontic and orthopedic treatment may include use of bands, brackets, distraction and stabilization of planes, elastics, headgear, max expansion of planes, etc. In pre-distraction planning, the orthodontist evaluates and determines the desired vector-based skeletal appraisal. The 4 influences present to affect the observed vector are the unique biomechanical characteristic of the selected distraction device, the orientation of the distraction device to the mandibular anatomy, the neuromuscular influence, externally exerted forces. If the distraction goal is pure or vertical elongation of the ramus with the unilateral posterior bite opening and no anterior movement, this is the best realized when the vector of distraction is perpendicular or acute to the patient's occlusal plane. The placement of the device parallel to the posterior border of the ramus or perpendicular to the inferior border of the body is not consistent with the goal of achieving vertical direction of distraction. The placement of a distraction device parallel to the posterior body of the ramus results in the oblique distraction vector as it relates to the occlusion. In the distraction goal is pure sagittal advancement of mandibular body. This is best realized when the vector of distraction is parallel to the patient's occlusal plane. The placement of a device parallel to the inferior border of the mandibular body is not consistent with the horizontal direction of the distraction as it would be oblique to the occlusal plane. If the distraction goal is achieved to achieve the both ramus and the body lengthening, an oblique vector is used. Oblique placement was defined as a greater than 90 degree of angulation because of the between the occlusal plane and the long axis of the distraction device. The vertical placement was defined as a 90 degree or less of angulation between the occlusal plane and the long axis of the distraction device. The third force that is presumed to affect the path of the tooth-bearing segment is generated by neuromuscular. The fourth influence that may affect the position of the tooth-bearing segment is the application of external force, the intermaxillary elastics during active distraction. It is believed that the observed occlusal response to the elastic forces is secondary to the molding of the regenerate and endothelial remodeling. Thus, intermaxillary elastics can be used to modify direction of the skeletal changes and fine-tune the occlusal outcome of the distraction. Intermaxillary elastics may be worn in class 2 and class 3 vertical or transverse bicolingual direction during the active phase of distraction. Anterior vertical intermaxillary elastics may be helpful in the direction of the anterior open bite and may be used transversely to correct the crossbite. The intermaxillary elastics may be helpful in the direction of anterior open bite and may be used transversely to correct the crossbite or lateral shift of the mandible during the active distraction. In this illustration, the mandible has shifted toward the contralateral side, resulting in the posterior crossbite. The ipsilateral side shows the open bite. The crossbite cross elastics combined with the mandibular lingual stabilization arch are used to correct the crossbite. Post-distraction orthodontic management. After consolidation and the removal of the plane, the orthodontist has to give the final finishing of the occlusion. If in the unilateral distraction cases, the orthodontist is often confronted with the posterior open bite on the distracted side and a crossbite on the contralateral side. The open bite may be managed with the gradual adjustment of the bite, with the crossbite resulting from the mandibular shift across the mid-sagittal plane may be corrected by the combination of transpalatal arches, lingual arches, intermaxillary arches, intermaxillary cross elastics, and the palatal expansion device. The intraoral mandibular distraction osteogenesis. The mandibular widening through the distraction osteogenesis corrects the basal bone problem by creating the new bone to accommodate the teeth and eliminate the need of dental extraction and offering the stable results. The preoperative intraoral view of the patient with transverse mandibular deficiency, and this is the postoperative view of after 14 mm of intraoral mandibular distraction osteogenesis to widen the mandible. The device are located as anteriorly as possible to minimize the interference with the tongue function, and the distractor is cemented by the orthodontist 1 to 2 days before the surgical intervention. The preoperatively occlusal view of the mandibular arch showing the lower anterior crowding and a tooth bone expansion of lens is given. The orthodontist must provide the root division in the mandibular osteotomy site to ensure the sufficient alveolar bone remains on both the sides of the planned osteotomy for the periodontal health of the dentition. Intraoral distraction osteogenesis protocol. The distraction device insertion. The device is inserted 1 to 2 days before the surgery. The osteotomy is completed and the distractor is activated to mm. Activation of distractor begins 7 days after the surgery. The distraction is performed at the rate of 1 mm daily. The distraction appliance is activated at the rhythm of once a daily. Orthodontic tooth movement should not begin until the removal of a distraction appliance 8 to 12 weeks after surgery. Once the desired amount of distraction is achieved, the cosmetic acrylic tooth is ligated to the orthodontic archway at the interdental gap. After the stabilization period, active orthodontic movement of the teeth with light progressive forces is re-established and the mesiodistal width of the acrylic tooth is reduced while the teeth adjacent to the osteotomy site are moved with orthodontic forces to close the interdental gap. Alter nearby complete bilateral mandibular ramus osteotomies. The bone appliance is secured to the buccal mandibular surfaces. The midface distraction in Munich and Mugler conducted a series of Lefort 3 and a monoblock distractions in a small group of patients with Apert syndrome. In 1997, the Journal of Craniofacial Surgery, Foley and Figueroa discussed the management of the severe maxillary deficiency in the childhood and adolescence, performing distraction osteogenesis with an external adjustable rigid distraction device. The modular internal distraction system allows the surgeon to fabricate custom internal distraction devices for virtually any region of craniofacial skill type. First generation system contains expansion screws capable of 15 mm and 13 mm of distraction. Depending on the distraction site and the osteotomy, any configuration of titanium plates can be attached to the distraction screw to permit the unipolar and possibly the biplanar internal distraction. A flexible activation cable is brought out through the distant and inconspicuous tape wound in the hair behind the ear. The clinical indication: the patient with cleft lip and palate with severe deficiency, retrusion at the age of 6 years typically will not be corrected by the standard orthodontic therapy alone. When severe deformities are present at the age of 6 years, the distraction osteogenesis can be used in combination with the yearly rapid palatal expansion to correct both the sagittal and the transverse maxillary deficiencies. Internal distraction osteogenesis performed in the children with cleft lip and palate as young as 6 years of age. Patients with syndromic craniosteogenesis have traditionally undergone fronto-orbital advancement alone at 4 to 9 months of age. The majority of treatment protocols addresses the mid-facial hypoplasia between 4 and 7 years of age using either monoblock or Lefort 3 osteotomies. When hypertaloorbitism is present, intracranial or subcranial facial bipartition is performed. Because of the mandibular growth, class 3 malocclusion occurs in early to later adolescence, the necessitating orthognathic surgery and occasionally repeated Lefort 3 osteotomy. Other possible indications for mid-facial distraction include correction of maxillary canting in hemifacial microsomia and other asymmetry malformations, apnea with associated mid-facial retrusion, the Treacher-Collins syndrome for zygomatic advancement, and mid-face retrusion of any case depending on the severity. The timing of surgery in children with syndromic craniosteosis and severe mid-face retrusion, monoblock osteotomies can be performed safely at younger than 1 year of age. In children at age 4 to 7 years undergoing monoblock and or Lefort 3 subcranial osteotomy, operative morbidity is also reduced. In children requiring mid-face distraction for obstructive sleep apnea, to correct retropalatal obstruction, mid-face distraction may be necessary in concern with the mandibular distraction to prevent the simultaneous correction of retropalatal or retrolingual obstruction. Surgical techniques: Lefort 1 distraction. The Lefort 1 osteotomy is performed in a stair-step fashion to provide adequate posterior bone for the attachment of distraction device. Because of the MID system provides flexibility, the types of titanium plates selected for the posterior and anterior distraction vary. To maintain a direct sagittal distractor vector, the anterior plate is generally bent with a step. It is necessary to make a complete osteotomy and the Therefore, the osteotomy is kept just below the level of intraorbital foramen and nerve. Leaf 4-3 distraction. A standard leaf 4-3 osteotomy is performed in the younger children who are at the risk of fracturing zygomatic maxillary suture region, and the anterior plate is confined and the rigidly fixed after the osteotomy, but before bone fracture. Leaf 4-3 osteotomy with the plates is secure to the malar eminence and the lateral orbital rim with the MID distraction appliance in place. The posterior plate is stabilized to the temporal bone. Underneath that temporal muscle, a 30 mm distraction frame is chosen and attached to the anterior and posterior plates. In leaf 4-3 osteotomy, typically 2 mm to 4 mm of distraction is performed in the operating room. The distraction is then begun on the 5th post-operative day at the rate of 1 mm per day. Once the appropriate portion to orbital distance has been reached or mild adopters have been produced with overcorrection of bone occlusion, distraction is stopped and the distraction gap is allowed to consolidate over a period of 2 months. Dental elastics are used to correct the occlusal abnormalities. Monoblock distraction. Monoblock distraction is applicable in children aged younger than 1 year but can be used in any age group. Monoblock consists of leaf 4-3, a frontal bone osteotomy. The distraction device is secured posteriorly to the temporal bone and anterior to the zygoma and lateral orbital rim. The flexible activating cable exists in the excite the skin above the ear. This is a 3-year-old baby with Apert syndrome, hyperteloorbitism, and flat facial fin. The preoperative lateral, that is the preoperative lateral photograph. The depiction of operative technique. The note: the facial bipartition was performed simultaneously with the distraction. Bipartition is stabilized with the rigid fixation, and distraction device is applied. The artist depiction of distraction devices is positioned. The postoperative frontal view, which is 6 months after the devices were removed. Postoperatively, the lateral photograph 6 months now the devices were removed, and the 25 mm of distraction is done. The combined maxillary and mandibular distraction osteogenesis. The mandibular elongation by distraction in patients with hemifacial microsomia is a simple and effective procedure to correct the facial asymmetry. The changes in the mandibular dimension result in the changes in the dental occlusion. These are minimal in children because of the rapid growth of maxilla and can be corrected easily with minor orthodontic treatment. The mandibular distraction in adults with hemifacial microsomia produces a good aesthetic results but leaves the patient with a severe alteration in the occlusion, requires the complex orthodontic treatment over a long period of time. To avoid this problem, an incomplete leaf 4-1 osteotomy is performed simultaneously with the mandibular corticostomy. Intermaxillary fixation is placed on the 5th postoperative day and distraction is initiated. After distraction, both the maxillary and mandibular occlusal planes became horizontal and facial asymmetry is corrected. There is a reduction in the treatment time and the cost when compared to the protocol of the mandibular distraction, followed by the perceived bite plate guiding the eruption of maxillary posterior occlusal plane. The software distraction screw is used in the system. In this system, allows the medial rotation of the bone, which closely imitates the normal development of the growing mandible. The chin is always medialized by the distraction, but in adults it is not always possible to align it precisely under the mid-sagittal plane. At the present time, the author believes that the simultaneous maxillomandibular distraction is the procedure of choice in patients with moderate and severe hemifacial microsomia who are older than 12 years of age. Reconstruction of neocondyle using transport distraction osteogenesis. The process of slow bone expansion by distraction osteogenesis in combination with the functional remodeling can also be used for the reconstruction of neomandibular neocondyle. This is the technique of transport distraction osteogenesis. The transport distraction osteogenesis is the technique of regenerating bone and soft tissues in a discontinuity defect. Osteotomy is made 1.5 cm from the end of the distal stump of the bone adjacent to the discontinuity defect, creating a transport disc. Using a distraction device, the transport disc is advanced through the soft tissue discontinuity defect, creating a new bone within the distraction gap as leading the edge becomes enveloped by the fibrocartilaginous gap. The mandible therefore acts as a bony template for the reconstruction, such that the new mandible created from the distraction process has the same size and shape as the native mandible covered with gingiva. This serves for enhanced prosthetic reconstruction. The transport disc is created from the ramus by making the reversible osteotomy extending from the sigmoid notch to 1 cm above the inferior border, preserving the angle of the mandible. The transport disc is now advanced superiorly 0.5 mm twice a day. Because of the leading edge of the transport disc becomes enveloped by the fibrocartilaginous cap. The ramal transport disc can be moved superiorly to create a new articulation. The patients are encouraged to open and close their mouth during the distraction process such that the transport disc remodels to form a new condyle. This technique was successfully used to treat the patient with degenerative joint disease on corneal reception and bony ankylosing. The craniofacial deformities are complex and require careful examination. The deformity may impose limitations on the treatment possibilities. Destruction expands the scope for the correction but requires careful planning and execution. Destruction osteogenesis has replaced orthognathic surgery to some extent and indeed redefined the envelope of the discrepancy. Thank you.